Right. So let's start. Good morning, everyone. And as I think I can see all are already attended my class, so not going much in detail. I would like to highlight the two things today. One thing is this offer, right? We got a lot of requests globally that make it more economical. So earlier, this all things, right? If you go and get these things, all it could be around 900 to 1000 USD, right? And we are regularly, I mean, people are purchasing with the same cost. But today is the, I think, last day, right? So whatever you can get it at 925 or 950 would be in the 200 only. So just keep in mind, probably it will expire by tonight. So those still really interested, you go through it, right? Let me know, or Pallavi, you have the number. This is my number, right? And this is Pallavi's number, and this is my number. So after you can reach out to us, so we'll guide you. So this is one thing I would like to tell. And second, very important thing is our YouTube channel. We are getting lots of feedbacks from the doctors who passed the exam, right? This is YouTube channel, right? So recently I updated it today only. There are more than 150 plus excellent videos. So if you see at least one video per day, one video per day, if you cannot able to do it one video per day, do it one video every 2 days. So within 2 days, so in a week you can have 3 videos. In 4 weeks you have 12 videos, and if you are having a 2 months of preparation, 24, 25 videos. This 25 video is equivalent to, let me tell you, 1000 MCQ. 1000 MCQ, because we never discuss one question. In one questions we discuss 100 questions, or many, I mean 10 questions in one question. So there are a lot of interesting and high yield things are there. So those who are unaware of this, same picture, this is my picture, medical MCQ for all. This is a official YouTube channel, thousands of close to 7,000 subscriber in short period of time. So you can get the advantage of it. Believe me, it would be tremendously helpful. This is not my feedback. This is feedback from the doctors who are every day, one, two, three doctors are, I mean, cracking the exam. They are calling us. They are giving their own feedback on the phone as well. So this is a conclusion. And another thing is like we have mobile applications. So those who are using our website, they can completely surf our whole website on the mobile phone, is on Android as well as on Apple. So it's a compatible for both the things, right? So these are the two things I think I would like to highlight today. And then we'll jump to the class, our high yield things, right? So we're gonna discuss very interesting questions today. So let's start and begin with the first questions. We did it few questions in the last session. So those who missed out, just go through it and do let me know for any help or for the assistance if they didn't get it. So let me start from where we left, right? So let's check out this very important and interesting questions, right? Yes, this is the first questions in front of your screen. What is the most common cause of Cushing syndrome? Administration of synthetic ACTH, use of medroxyprogesterone, iatrogenic steroid administration, Cushing's disease, right? So this is one question. As I told you, we have many other questions as well along with this. Next question is how you differentiate between Cushing syndrome and Cushing's disease. Are they different things or the same thing, right? Or if it is different, what's the difference? How you diagnose the heart hypercortisolism, right? And how you know the cause of hypercortisolism? What is a low dose dexamethasone? What is a high dose dexamethasone? Where you use this? Where you use this? This all are the absolutely high yield questions for the exam point of view, right? So now your time starts now. You have 15 seconds to think of this question, right? What is the answer of this? I need one volunteer as usual every time to discuss the question. Yes, please. Yes, Dr. Anisha, what do you think? What could be the most common cause of Cushing syndrome?
Is iatrogenic steroid administration.
Wonderful, brilliant. So let's discuss that part. Iatrogenic steroid administration. So what is basically iatrogenic steroid administration? What do you think and what do you understand by iatrogenic steroid administration? Any idea? Yes or no? Yes or no? That's fine. If you don't know that, you can say no. Fine, no problem. So just save the time. Do you know how you
I'm not sure.
differentiate? No, fair enough. Do you know what is the difference between Cushing syndrome and Cushing's disease? Can you tell me, Dr. Nisha, what is the head-to-head comparison between Cushing syndrome and Cushing's disease? Very important. Very, very important. Yes, how exactly you define? Or it is the same thing. I mean, it's not a different whether you call it Cushing syndrome or disease, it's same thing. Yes, please. Anyone else? Anyone? Open up your mic and you can speak. Yes, Dr. Ishara, would you like to comment on this? Dr. Shahila, how you differentiate Cushing's syndrome from the Cushing's disease? Any idea,
So,
Doctor? Yes, yes. Go ahead.
sir,
Sorry.
it's a pituitary tumor, sir. Uh,
Pituitary tumor. Okay. So what is pituitary tumor? If there is a tumor in pituitary, what it is? Cushing's disease, syndrome, ectopic, what exactly? Fine. So this is let me give you the complete idea. I think you guys are still confused. So I'll completely clarify all the concepts today, right? So first
so,
of all,
is this a symptoms, signs and symptoms, sir, for Cushing syndrome,
yeah.
which is
So
produced?
yeah. So Cushing syndrome is a umbrella things. Let me first give you the brief idea. So when you say Cushing syndrome, this Cushing syndrome is like umbrella, right? Under this umbrella, lot of things. One of them is Cushing's disease specific. Another is adrenal cause. Another is ectopic. These are the three major things, right? So basically, let's understand first the basic, right? Because there are lots of doctors. I mean, they are confused. So one first of all is a hypercortisolism. Hypercortisolism and hypocortisolism. We'll discuss both the things. Hypocortisol, like hypertension and hypotension, like hyperthyroidism, hypothyroidism, hypernatremia, hyponatremia, hyperglycemia, hypoglycemia, hypercortisolism, hypocortisolism. That's it. So this is first of all the basic understanding which you must keep in mind. So cortisol could be normal, cortisol could be high, cortisol could be low, right? So whenever there is a high cortisol, it is called as a hypercortisolism, right? Hypercortisolism, right, means increase the cortisol in the body, right? Simple. If you understand this, 10 questions you can solve, right? Any tricky, complicated 10 questions you can solve. So first of all, can anyone tell me, right, what are the screening tests for the hypercortisolism, or which test, by which test you know that this patient is suffering from the hypercortisolism? Is there any name of the test we called as a screening test?
Dexamethasone suppression test.
Okay, so one name is dexamethasone suppression test. Okay, this is the only test, or is there any other test apart from this? I want to know all the tests, right? If it is not in the options, right, then what is the next option?
Overnight cortisol test.
Sorry, madam.
Overnight cortisol test.
Wonderful. Overnight cortisol salivary test. Overnight cortisol. Okay, is there any test missing in this list?
24-hour urine.
Wonderful, brilliant.
For
24 hours urinary cortisol. So these are the three tests, which is a screening test. It is not at all a diagnostic test. This is screening test. So any patient who has a obesity, who have hyperglycemia, who have hypokalemia, who have a stria, who has skin changes, who has a weight loss, and you think that this patient is a Cushing syndrome or it's suffering from the hypercortisolism, right? So how the diagnosis start from the clinical suspicious, right? When patients enter into the body, patient enter into your body with the chest pain, right? So this is symptoms. You are immediately pop up with the MI, acute myocardial infarction. You don't want to miss it, right? Then you do the ECG, then you do the enzyme, right? Then you do the PCI, then you, if not available, then you go thrombolytic, blah, blah. This is how the flow generates for each and every patients globally, right? So whenever patients enter into the body with the symptoms, so you need to know what are the sign and symptoms of Cushing syndrome. That we'll discuss very shortly, but I would like to make you understand. Screening first, by any of this screening test, you first confirm, right? Once confirm the test that okay, fine, this patient has hypercortisolism. Say, for example, you did a dexamethasone suppression test, right? So now I would like to understand dexamethasone suppression test, or better word is low dose dexamethasone suppression, right? So low dose dexamethasone you had given to the patient. What happens in normal individual? What happens in hypercortisolism? It's very important. How do you get to know what do you mean by dexamethasone suppression test? So I want to do the dexamethasone suppression test for myself on my body, right? What happens if it is normal? What happens my cortisol is high? How you interpret? Anyone? It's a very, very, very basic questions. You told dexamethasone suppression test. So you did a dexamethasone suppression test, and now you are checking the cortisol. Cortisol is normal or cortisol is low, or what happens to the cortisol, and what happens? What's the diagnosis? Are you getting me? Yes or no? At least tell me
In
yes or no.
normal, sir, in normal individual, it will be early morning cortisol will be low.
Fine.
अबे
So,
लेक्चर
so
कर रहा है भाई, बाद में बात करो।
yeah.
लेक्चर लेक्चर
Right, sorry, somebody is disturbing. So I want to. I muted all, so you can unmute your mic. So anyone, I mean, this is so simple question, right? You had an dexamethasone test, right? How you interpret whether this patient is suffering from hypercortisolism or Cushing syndrome or not Cushing syndrome? Simple question. Nobody knows the answer. Surprise. Right? So this is how we go to the basic, right? Until and unless we understood this basic, we don't know. Anyway, so low dose dexamethasone suppression test, right? If it is right, so if you give low dose dexamethasone suppress and dexamethasone suppression is there, right? If it is there, it is normal. If there is a no right, if there is no suppression and cortisol level is high, right? It is a Cushing syndrome. So this is the first entry point of Cushing syndrome. First entry point, right? So what is the first entry point? In suspected case of Cushing syndrome, right? Dexamethasone suppression test is done, right? And there is a no suppression. Dexamethasone suppression is not there, right? No suppression of cortisol means cortisol is high. This is hypercortisolism, number one, right? After this is first step. They can ask you 100 questions related with this. If you understood this well, any questions, believe me, you diagnose. So this is first question in exam, right? Second question in exam, right? If you diagnose this patient as a Cushing syndrome, that is hypercortisolism. Hypercortisolism is not nothing other than hypercortisolism. It's a umbrella term. There are a lot of things. So in Cushing syndrome, right, when you diagnose that okay, patient is hypercortisolism, patient's cortisol is high, right? Now second thing is find out the cause, right? What is the cause of Cushing syndrome, right? So there are three causes. Just let me tell you. One is a pituitary cause, second is a adrenal cause, and third is a ectopic cause. Ectopic means outside the pituitary and adrenal. This is ectopic, right? So this comes to 100% cause of hypercortisolism. So how did you get to know, right? So you diagnosed already that patient is hypercortisolism, is Cushing syndrome. Now you want to know the cause. So what you do, the second test, second image, one test is a dexamethasone first test. Once you confirm, sorry, then you do the ACTH. ACTH, there are two possibility, major possibility, right? ACTH is low, ACTH is high or normal, high or normal, high or normal. Understand this, very important. And when the ACTH is low, low means local cause, low means local cause. This is how I remember. Low means local cause. Local cause is adrenal. That's it, adrenal, right? And if it is high or normal, how you supposed to know whether it is pituitary or ectopic? Then the next test comes is a high dose dexamethasone test. High dose dexamethasone test. If you give the high dose dexamethasone test and right there is a suppression of cortisol, it is pituitary. And when there is a no suppression of cortisol, still the cortisol is high, it is ectopic. That's it. That's it. I'm done. That's it. I'm done. Right? So this is the cascade. This is the cascade. Until and unless you understand, I challenge you, you read hundred of time this, you never ever got the idea. So suspicious point for any hypercortisolism or Cushing syndrome, first do the dexamethasone test or low dose dexamethasone test. If it is suppressed, normal. If not suppressed, then it is hypercortisolism or you diagnose it is a Cushing syndrome. That's it. Once you diagnose the Cushing syndrome, you need to know the cause, right? So say for example, for anemia, say for anemia, right? You diagnose the low HB, right? So low HB is the finding. Now your job is to find out the cause of low HB. So first confirm the low HB, right? So first confirm the low HB. Here first confirm the hypercortisolism. How you confirm? With cortisol, right? Or low dose dexamethasone. Once you confirm, you get to know the cause, right? You get to know the cause. You have a chest pain, you confirm it is acute MI. So there is a STEMI, right? And then you do the angiography or CAG or PCI, right, to know the cause, what is the site, blah blah. That is how it works, right? So once you confirm the Cushing syndrome, right, you need to do the ACTH level, adrenocortical tropical hormone. If it is low, low means local cause. Local cause is adrenal, within the adrenal. If it is high or normal, what could be the cause? Then you do the dexamethasone, high dose dexamethasone suppression test. If it is suppressed, then it is a pituitary cause. If does not suppress, and it's ectopic cause. That's it. Any questions or confusion to anyone? Any
No, sir.
comment on this? No comment. We are close to 30 doctors. Any comment? Everybody understood well? Yes or no? At least tell me
Yes,
yes or no. Dr. Savita,
yes,
you understood well.
Yes,
Yes.
sir.
Wonderful. So this is very
Yes, sir.
complex things, but I put it in a simpler way, right? So now your job is extremely easy to answer any questions. Now let's little move ahead. Answer for this question is a iatrogenic. Let's see the all dissect the things, right? So now job would be easy because we have the understood the things, right? The most common cause of Cushing syndrome, iatrogenic steroid, right? So that's it. Cushing syndrome. What is Cushing syndrome? As I told you, it's umbrella term, right? So it Cushing syndrome is any cause of cortisol excess. Any cause means it could be adrenal, it could be pituitary, it could be ectopic, right? So any cause, right? So it's an umbrella term. Cushing disease just pituitary. That's it. Pituitary, right? So whenever somebody is saying patient is suffering from Cushing's disease, you don't need to think of adrenal, you don't need to think of ectopic, only and only pituitary, right? So it could be microadenoma, it could be macroadenoma, it could be pituitary hyperplasia. So we'll see it bit in detail, no worries, right? Another things, right? So once you confirm this low dose dexamethasone test, I already told you, right? Cushing syndrome, there is no suppression. In normal individual, there is a suppression in normal. So if I underwent for the low dose dexamethasone test and I'll somebody check my steroid, it's suppressed, right? But in Cushing's, no suppression. High dose dexamethasone, I already told you to know the cause, right? If suppression with high dose, it is pituitary, no suppression, ectopic. That's it. So this is what I told you already, right? So this is brilliant slide, one slide which explain self-explanatory. So that's it. This is what we understood, right? So let's jump to the Cushing syndrome and disease. So Cushing syndrome in nutshell, right? This is all cause of hypercortisolism. All cause, not one cause, all cause. And disease is only one cause. Which is the cause? Pituitary adenoma. That's it. ACTH level, right? As we seen it, high ACTH level, right? High ACTH level, right? Remember my chart, right? Earlier chart, right? Here it could be low, it could be normal, it could be high because there are lots of causes, right? That is why this is the variation. So by ACTH, you may not know. You need to do further testing like high dose dexamethasone. So right, so definition is this: all cause, here pituitary cause. ACTH level could be low, normal, high. Here the absolutely high. No other options. It is a broad condition. This is a specific subtype of hypercortisolism or Cushing syndrome. Causes could be exogenous steroid. That is our answer. Adrenal tumor, ectopic or pituitary. So all causes, whatever the causes in the body from head to toe, all causes, if you compile it is Cushing syndrome, but you find out the exact cause, it is Cushing's disease, especially the pituitary. High dose dexamethasone, as we seen, is there is no suppression. Here the suppression. Once again, Cushing syndrome, right? You do the low dose dexamethasone test, right? There is a no suppression. No suppression means Cushing syndrome is confirmed. After Cushing syndrome, you do the ACTH. ACTH, right? If it is low, local cause, right? That is a adrenal. If it is a high or normal, you do high dose dexamethasone test, right? If it is suppressed, it is pituitary. If it is does not suppress, it is ectopic. That's it. One simple chart will explain you hundreds of causes, right? So high dose dexamethasone test, you see the chart, right? High dose dexamethasone, usually no suppression. There is a suppress. High dose dexamethasone test, right? If it is pituitary cause, suppress. If it is ectopic, it does not suppress, right? Treatment depends on the cause. If it is adrenal cause, treat the adrenal. If it is ectopic cause, treat the ectopic, right? Here only treatment is pituitary surgery because there is a tumor in the pituitary gland. Pituitary gland is like this, anterior pituitary and posterior pituitary gland, right? So you need to operate, right? Pituitary tumor, right? Or pituitary adenoma, you need to operate it. There is no other treatment. No medication will help this patient until and unless you remove the tumor, because cause is tumor. So you remove the tumor. So in Cushing's disease, there is no logic in operating the adrenal gland. Why? Because it is not the cause. Why you want to operate the adrenal gland when there is a disease situated in the high pituitary? Is that clear? So this is concept, right? So this is head-to-head comparison. You must remember it, and if you remember it, it would be good for you, right? So we discuss all everything. So last, this is the chart, full algorithm, right? Full algorithm. Once again, probably the repetition, but it is extremely important, right? So and that's all. Then we'll move ahead for the next question. So once, first of all, full algorithm or summary, positive screening test, right? Screening test is positive. Three tests: low dose dexamethasone test, salivary test, 24 hours urinary test. Once you screen and screen test is positive, means Cushing syndrome is established, right? By screening test, your second test is ACTH test. What happens to ACTH? ACTH is low, means local cause, means adrenal cause. You do the CT MRI just to get the adrenal tumor, and if adrenal tumor is there, you remove it. That's it. That is the treatment. And once, if it is low, but what if it is high or normal? Then come the high dose dexamethasone test. High dose dexamethasone suppression is there. It is a pituitary cause, pituitary adenoma. How you diagnose? By MRI, right? Do MRI and treat the patient. Do the pituitary surgery. And if there is no suppression, means it is ectopic. And when there is ectopic, commonest is in the lung. So that is why, right? So you do the CT chest abdomen and try to find out the cause. Where is the ectopic? Ectopic means outside. Ectopic pregnancy. So normally pregnancy happens in the uterus, right? So baby happens in the uterus. This is in the uterus, baby in the uterus. But if it is out of the uterus, it is called ectopic pregnancy. Ectopic. So outside uterus. Ectopic means outside. So outside the brain and adrenal is ectopic ACTH, and that could be in the chest or in the abdomen, right? So that is the reason. That's it. So this is what the Cushing syndrome's basic all understanding about the various different tests, and now you supposed to interpret this test. So I think I'm very much clear from my side for explaining you guys in a best simple possible way how you do diagnose, go reach up to the diagnosis, ACTH, low dose, high dose. So if still have, I mean, anybody has any confusion or doubt, I would spend more 15 minutes. If you are not asking, I'll go ahead. Any questions with this?
No, sir.
Sir,
Any question?
sir, can I ask the
Yes,
role of
yes.
this
Any.
concentropin and metirapone? Like, do we have questions concerning
Yes,
that
we
one?
have
And
question. We have questions down the line, right? So
okay,
you can
okay,
write down
okay.
your question. I will sort out surely. So, but so far for this question, all clear, right?
Oh, okay, sir. Okay.
Wonderful. So there are a lot of things. I have many slides. So let me go through the last slide for Cushing's, right? So causes of Cushing syndrome. Endogenous means inside the body, exogenous, right? So administration of exogenous corticosteroid is one of the most common cause. That is what our answer is. Endogenous means inside the body, right? So pituitary, that is Cushing's disease. Pituitary is the Cushing's disease. It is statistically around 70% patient, right? So first rule out the Cushing's disease, right? Because 70% of the patient cause of hypercortisolism is pituitary. Three problem in pituitary: microadenoma means small tumor, macroadenoma means large tumor, and per se as a whole, pituitary is enlarged hyperplasia. So three causes: microadenoma, macroadenoma, and pituitary hyperplasia. Any of this can cause hypercortisolism, and this is Cushing's disease. What is the endogenous? Endogenous means inside the body. So small cell lung cancer. Small cell lung cancer is ectopic. Is ectopic. Is ectopic. 10%. Carcinoid in the lung, medullary carcinoma of thyroid, and pancreatic islet cell tumor. So you go and read it, man 1 and 2, multiple endocrine neoplasia 1, multiple endocrine neoplasia 2, A and B. There are three category. So we had a last this our videos had a MEN question where we sorted out all the causes and what are the what includes in man 1 and man 2. So this is the ectopic. That's it. So this is what the rest of the things I already told you. So I don't want to go in detail again, right? So most common cause is the exogenous administration iatrogenic things, which is the most common. And second most common, if they ask you what is the second most common amongst the list, right? So most common is number one is the most common, right? So this is the most common, right? This is one most common, and right, Cushing's disease is increased cortisol from pituitary. It is disease, right? So that is there. But amongst these two, Cushing's disease and administration of iatrogenic steroid administration, right, is the most number one. This is number two cause of hypercortisolism. So any patient comes to you with the Cushing syndrome, look out the patient is already on the steroid or not. If it is there, right, your job is done. So you reach up to the diagnosis, right? So that's it from my side. Let's jump to the next important and interesting questions. Get out of the Cushings and now switch your gear from Cushings to another things, right? Let's see the now we see all thyroid cancer. So it's a very big topic, Cushing syndrome and Cushing's disease and all. So we covered it almost. Now we'll cover the all kind of thyroid cancer, whatever the confusion in your mind and all. So we'll discuss all in this question. 46 years old woman with thyroid nodule is found to have normal thyroid function testing. The fine needle aspiration came back as indeterminate for follicular adenoma. What is the most appropriate next step in the management of this patient? Are you going to do next CT scan with contrast study? Are you going to do a surgical removal, ultrasound of the thyroid and neck, and calcitonin level and PET CT scan? So this is one question, obviously, which is in front of our screen, right? What are the other questions? How to diagnose? Number one. How to differentiate thyroid cancer? Number one, right? And there are a lot of thyroid cancer, right? We'll see head-to-head comparison of all thyroid cancer in next slide. Can anyone tell me what is the most common thyroid cancer? Second question, which thyroid cancer has a best prognosis? Third question, which thyroid cancer has a worse prognosis? All three different question in exam. Yes, anyone, any volunteer.
The most common is papillary carcinoma, papillary thyroid
Wonderful.
carcinoma.
Brilliant, Sonia. Papillary, absolutely. Papillary carcinoma, which accounts for almost 80 to 85% of the all thyroid cancer. Wonderful. So one answer is done. Tick. Correct, perfect. Yes, Sonia. What would be the best, right? Which thyroid cancer has the best prognosis? There are two prognosis. Best means good cure rate, that is called best. Worst cure rate, that is called bad. So what is the best cure rate? Which thyroid cancer has the best cure rate or best prognosis down the line? Or in simple layman term, which thyroid cancer patient lives longer or longest? Yes, Sonia.
The worst, I think, is anaplastic.
Anaplastic is the worst. Okay, so what's the best?
This one only is a papillary, sir. Best
Wonderful,
prognosis.
brilliant, 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 wonderful. So this is what the thing is, right? Wonderful. So let's go to the again the our basic. Now, what is the answer, Dr. Sonia, for this? As you started this, so let me understand from your side. What is the diagnosis here? So those who are joining me first time, they never have seen this triad. This is my triad, MCQ triad, right? Diagnosis, investigation, and treatment. We need to know the each and everything about any MCQ solved from now onwards or from today. You ask yourself three questions. What is the diagnosis in this scenario? Right? How you reach up to the diagnosis by doing the investigation, and what is the treatment? What is the treatment? Ask yourself always three questions. So, what is the diagnosis? I'm asking you the normal questions, Dr. Sonia. What could be the diagnosis of this patient? Did you get any idea?
This can be so for related to follicular only, the follicular.
Fine. So you give me one name of this diagnosis or differential diagnosis or whatever you think that okay, this is the thing, sir. Because every diagnosis you must have some diagnosis, the clinical diagnosis, what we call as a clinical diagnosis, right? Hypertensive, diabetic, obese, smoker, strong family history of MI comes to me with the chest pain without doing single penny blood test, ECG, enzymes, echo, PCI. I can differentiate. Okay, clinically it's look like a MI. What is the clinically it looks like? Anyone?
Follicular adenoma or follicular carcinoma.
Okay, so this could be indeterminate, means indeterminate for follicular adenoma. So you have still there is a confusion between adenoma or carcinoma, right? Adenoma, indeterminate means it is not confirmed. Indeterminate, it is extremely important in this whole scenario. So 46 years woman who has a thyroid nodule found to have normal thyroid function, means T3, T4, TSH is normal. Fine needle aspiration cytology you did it, which is like indeterminate. It could be, it could not be, right? That is called as the indeterminate, right? What is the most appropriate next step in the management of this patient? So what you supposed to do for this patient? Now tell me, and why? Whatever you
Excision
select,
biopsy.
you do why? Yes, doctor.
Excision biopsy.
Okay, Ranmini. So why you want to do the excisional biopsy of this patient? What you are interested by removing the thyroid or doing the excisional biopsy of this patient? Is
We can come
FNS
to
is not enough?
diagnosis with the adenoma or the carcinoma. We
Wonderful,
can see
brilliant. So you
the
can reach up to the
histology.
diagnosis. Wonderful. So adenoma or carcinoma. So biopsy just fix in your head, right? Biopsy is always better than any FNSE in any part of the body, whether it is a breast cancer, whether it is a lung cancer, whether it is a colon cancer, whether it is a prostate cancer, you name the disease, you name the cancer. Whenever there is a cancer, biopsy is the answer, not the FNSE in general, right? If you don't have biopsy in your options, select FNSE, but in both in option, select. So answer is this surgical removal of this thing. So now let's dissect these questions more bit in detail and look at the all various possibilities. So correct answer is the surgical removal or excisional biopsy of this patient, right? Or diagnostic lobectomy, right? So explanation high yield for exam when FNSE reports follicular neoplasm, suspicious for follicular neoplasm, indeterminate for follicular adenoma or Bethesda category 4, right? So these are the reporting. So our is a indeterminate for follicular adenoma. It means cytology cannot distinguish between adenoma from carcinoma, right? Right, because FNSE they cannot give you idea about the capsular invasion, they cannot give you idea about the vascular invasion, and which is important for you to know, right? Because malignancy does not invade, benign things does not invade, malignant does, right? So this feature cannot be seen on FNSE. So only FNSE or is not sufficient, and you need a surgical excision of this patient, right? So concluding the talk, this is the answer. Let's dissect why not are the other options, right? Our job is not just to get the answer, but why not the other options, or why we excluded the other option? Why not CT scan, right? Why not CT scan? So let's see why not. So CT scan of the neck, right, not required in a typical thyroid nodule, used only in a large goiter with the compressive symptoms. This is the indication of doing the CT scan in thyroid malignancy or suspected. Ultrasound, you already did it ultrasound. She already had a FNSE and FNS is usually done after the ultrasound, so there is no use of doing the ultrasound right away. And ultrasound does not differentiate between follicular adenoma and carcinoma, so it is also not involved. We need to differentiate this between this, and only thing which differentiate between this and this is excisional biopsy. That is the answer. Calcitonin level at this point of time is not required, only required or needed when medullary thyroid carcinoma is suspected, right? So indeterminate follicular lesions are not medullary thyroid carcinoma, right? So what's the POL, right? So follicular neoplasm, indeterminate for follicular adenoma, diagnostic lobectomy or external biopsy needs to be done for this patient, and that is why that is the answer. Let's jump to the let's deep dive into the carcinoma world of thyroid, right? So this is what interesting. There are hundreds of questions in this slide, right? But you need to pick up the high yield. I will tell you what are the high yield, what they ask exactly in the exam, right? So in this slide there are 10-20 questions. In one slide there are 20 questions, right? Most commonest amongst all cancer, answer one MCQ in exam. Most common amongst papillary, follicular, medullary, aplastic, Hurthal cell. Which of the following carcinoma is most common? First MCQ is done. Most common is this. Which one is the second most common? Follicular. This is medullary 3.5%, 2% very rarely, right? Let's see, papillary, young adult, middle age, medullary middle age, anaplastic elderly does not cause in a young or middle age. It's in the elderly. Hartal is in the elderly. Very important, because when they give you the age, 60 years of male presented with the blah 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 symptoms, never ever think of papillary. Think of anaplastic or Hartal. Both are happen in elderly, not in the young age. Right? Etiology is radiation exposure. Here folliculars most common, iodine deficiency. Third is a man. 2A, man stands for multiple endocrine neoplasia. Those who don't know, you go and read it. There are three types. Man 1, 2 has two category, 2A, 2B. 1, there is no AB. Man 1, man 2A, 2B. Go and read it. Origin of the cell, right? Follicular cell. Here also follicular cell. Here parafollicular cell. Undifferentiated cell, right? Here the hormone markers increase thyroglobulin. Here the increased thyroglobulin, medullary carcinoma of thyroid. They will give you 100% in exam. Increase calcitonin increase, right? Here thyroglobulin. So thyroglobulin is almost increase in all except medullary thyroid carcinoma. Genetics, I think you don't need to go much in detail of genetics, right? If you are interested, we'll later on discuss being a medical oncologist, right? But I would like to give you the how they spread. That is more important, right? So histology. This is the high yield question. Again, high yield question. Most common is papillary. Second most common is follicular, right? Third question in exam, orphan and nuclei or samoma bodies, orphan and nuclei. It is marked as a star. It is marked as a star. Important. So they say, and they give you the histopathology, right? And then they say that you did a this thyroid biopsy and you see the orphan any nuclei or samoma body. What could be the diagnosis? It's papillary. They say did the biopsy, there is a capsular and vascular invasion, follicular. This is the amyloid stroma or spindle cell, it is medullary carcinoma. Anaplastic giant cell or spindle cell, right? This is the something specific which you need to mug up, believe me, right? And eosinophilic granular cytoplasm, Harthal. So this is one you need to mug up, believe me, right? Spread, how the spread, most common papillary is 80-85%. How do they spread? It spread lymphatic spread, so they are limited to the nodes. They will not metastasize to lung, liver, bone and brain, not usually, not, right? They are local spread, and that is why local spread, right? There is a prognosis is excellent. Local spread prognosis is excellent. Why excellent? Because least aggressive, just spread locally. So you need to do some local treatment like thyroidectomy and radioactive iodine, right? And here there is a capsular inversion and vascular invasion. So by vessel, they can go any part of the body, especially, right? So especially in the bone and the lung. So there is a widespread metastasis is also there, right? So they usually don't get metastasis. Extremely important for clinical point of view, right? And prognosis is good but not the excellent. Why? Because it has a widespread, so it has overall good experience, sorry, prognosis, but it is not excellent. So excellent or based, is the best prognosis is papillary, and worst, very poor, worst is anaplastic. Worst, I can say worst, high mortality rate, right? So how you diagnose this thyroid cancer? By histology. Number one investigation is histology. Whatever they give, T3, T4, TSH, blah blah, thyroid sonography, this, look at the histology. That is the only thing which can diagnose. So this is, I think, bit exhaustive slide, but I think it brings lots of clarity about the lot of thyroid cancer. Are you getting me? Yes or no?
Yes, sir.
Yes, sir.
Wonderful, brilliant. So you can later on catch with the our videos on this. So you can take a picture. Don't worry, I don't mind. Right, this is what the thing is. So you need to little mug up. You need to understand. You don't, right. If you understood well, the things would be easy. Right. So let's just jump to the next question. Uh, 58-year-old secretary present with asthenia, hyperpigmented changes on her elbow and inner cheek. She also has noted her blood pressure is low and she is dizzy when she stands up. She has lost 10 pounds and has some nausea but no vomiting. A recent test for coccidomycosis was positive for this secretary who is 58 years old. Appropriate testing at this point of time includes CT scan of abdomen, esophagoduodenoscopy, glucose tolerance test, ACTH stimulation test. So just and this is completely clinical scenario, right? Complete clinical scenario. So now again my triad will come into the picture, right? My triad will come into the picture. You need to first think of this. This is number one job. What this patient is suffering from, until and unless you know the answer, your options is 99% wrong.
Addison's disease.
Brilliant. Addison's disease. Now tell me, Dr. Saila, how did you get to know the Addison's disease? Can you tell me the point in favor of Addison's disease?
The asthenia and hyperpigmented changes on the elbows and inner cheek.
Okay, fine. So this asthenia is number one. Hyperpigmented
Pigmented
changes number two. Number three is blood pressure is
blood pressure
low.
is
That
low,
is number
hypotension.
three, right? Weight loss is also there. Number
Okay.
four. Nausea is also common, number five. And this recent test coccidomycosis was positive. That is also clue, because after this infection, the adrenal gland, this is renal. I will show you the anatomy. This is a renal kidney, and above the kidney, this is adrenal. This is adrenal. So because of this infection, coccidomycosis infection, adrenal gland is destroyed. Adrenal gland is destroyed means the main job is to release the cortisol, right? So cortisol is not released. It is called hypocortisolism. Hypocortisolism, and hypocortisolism, the name is Addison's disease. If hypercortisolism, it is Cushing syndrome. If it is hypocortisolism, it is Addison's disease. If hyperglycemia, diabetes. If hypoglycemia, low sugar, hypoglycemia. Two extreme. Is that clear to everyone? Yes or no? At least tell me yes or no. Yes or no?
Yes, sir.
Yes, yes, sir.
Yes, sir.
Yes,
Yes,
sir.
Wonderful. So this is a brilliant scenario,
Yes.
brilliant scenario. What point favor is in the right? So your knowledge should be little high suspicious eye. You should have high suspicious eye. So by clinical, this patient has a classical symptoms point strong towards primary adrenal insufficiency. Primary adrenal insufficiency means primarily problem in the adrenal gland. And the name is Addison's disease. The name of this gentleman who described it, his name is Mr. Addison, and that is how it names comes. Mr. Addison should describe it. So it's a Addison's disease. No other logic for Addison, right? So primary adrenal insufficiency. Key clue in the everything is there in asthenia. Yes, it is there. Hyperpigmentation. Yes, it is there. Low blood pressure and dizziness. Yes, it is there. Yes, dizziness means orthostatic hypertension. Yes. Lost 10 pounds. Yes. Nausea is there. Yes. Positive test for coccidomycosis. Yes. Coccidomycosis can infect and destroy the adrenal gland, and destroy the adrenal gland means adrenal gland is no more now producing the cortisol. Hypocortisolism, the name is Addison's disease. That's it for adrenal insufficiency. Is that clear to everyone? Yes or no?
Yes, sir.
Yes. Yes, sir.
Yes.
Yes, sir.
Wonderful. So I think it's all self-explanatory. You now read the scenario, everything is there, everything is there. Only we need to have high suspicious. We are confused. what is the diagnosis, but it is absolutely classical Addison's disease. So now you never ever forget after our discussion, I think in exam, right? So now somebody was asking the rate. The correct answer, right? So Addison's disease. Now earlier somebody asked me the syntropine or giving some injections, right? So we reach to the diagnosis. So our triad is done, right? Addison's disease. This is diagnosis. How you supposed to diagnose? If you confirm this, you do the cortisol level. Cortisol level would be low. So this is Addison's disease or primary adrenal insufficiency, right? And we need to look into the treatment as well later on. So this is one thing is confirmed Addison's disease, right? Now, what you want to do in the Addison's disease? Are you going to do a CT scan of abdomen? Are you going to do the esophagoduodenoscopy, glucose tolerance test, ACTH? So remove this glucose tolerance test. We are not discussing about the gestational diabetes or glucose tolerance test. It's gone. I think esophagoduodenoscopy, what you are, we are not going to deal with the GI things, right? So probably you have little confusion between this and this test, isn't it? Yes or no?
Yes.
Yes, sir.
Yes.
Wonderful. So, right. So we'll nail to the diagnosis, right? So this is what the thing is, right? So answer is ACTH stimulation test. What is the ACTH stimulation test? We'll discuss and understood rather than mug up. The best initial confirmatory test for diagnosing adrenal insufficiency is ACTH stimulation test, right? So what you give? You give synthetic ACTH. The fancy name is cosintropin, right? What happens? So this is adrenal gland. This is a kidney,
Yes.
right? This is a kidney, right? So this is kidney and this is adrenal gland. So adrenal gland in Addison's disease, adrenal gland, it is not secreting cortisol. Understand? Not secreting, right? Or there is a insufficiency, in a primary adrenal insufficiency is there, right? So what you do when you give the cortisol, simple, right? What do you do? Give the ACTH, synthetic ACTH, right? Normal adrenal gland increases the cortisol. So if you give it, would you think that the cortisol level will increase in the Addison's disease? Yes or no? Would you
Yes, sir,
think
I
the
think.
cortisol, there is no cortisol in the adrenal gland.
No, sir.
No,
Mm,
sir.
It will not it
It
will not
fails to
reduce,
rise. Mm.
right? It fails to rise. Why? Because there is no
Fails
adrenal, na?
to
Right?
Yeah.
There is no
hypo.
adrenal is not producing at all. That is why you have insufficiency. That is why you have primary adrenal insufficiency. Means adrenal is no more producing the cortisol. If somebody gives to me, say for example, this Dr. Munjal, right? Somebody give me the cortisol, my adrenal is working well, cortisol will increase, right? But somebody who does not have cortisol, whatever you give, what will going to increase? Nothing, because nothing is in the factory. Nothing inside there. If it is something is there, you can release it, but there is nothing inside the adrenal. So normal adrenal is there, cortisol will increase. Primary adrenal insufficiency, cortisol fail to rise, or
Failed.
there is no increase in the adrenal. Oh, sorry, this hormone cortisol. Is that clear? Yes or no? This is concept. If you don't understand,
Yeah.
you always every time confused.
Yes,
Is that
sir.
clear to everyone?
Yes, sir.
Yes, sir.
Wonderful, brilliant,
Yes, sir.
brilliant. You all, I got a brilliant community. Wonderful. I'm lucky. Brilliant. Why not the other options? CT scan of the abdomen. These are the two confusing and closest answer. This is done after confirming the adrenal insufficiency to look for adrenal destruction, to look for infections, to look for hemorrhage or look for cancer. Right? So first like this, you confirm with the low dose dexamethasone, you confirm that this is Cushing syndrome. Once you confirm, then you go for the cause. Same here. First, you confirm the this Addison's disease, right, by giving the cosintropin test or giving the cortisol, right? Once you see that, oh, there is a no rise in the cortisol, means it's Addison's disease, then you go for what is the cause of Addison disease. Then you do the CT scan. Why you want to do the CT scan? Just to get the anatomical and physiological idea about the adrenal gland, right? Whether adrenal gland is distracted with a coccidomycosis, or is there any another cause in India is very common is tuberculous infection. TB of adrenal gland will absolutely destroy the adrenal gland. There is no more cortisol released from the adrenal gland, and patient developed and diagnosed as a Addison's disease. So Addison's disease is not the diagnosis. You right, diagnosis is right the cause. You need to find out the cause. Like anemia is not the diagnosis. Anemia is a finding. Anemia is a finding. What is the diagnosis? Sickle cell anemia is diagnosis, right? Aplastic anemia is the diagnosis, right? Likewise, right? Hypocortisolism is not the diagnosis. It's a finding. What is the diagnosis? Adrenal destruction is diagnosis. Adrenal infections by TB is diagnosis. Adrenal hemorrhage is diagnosis. Adrenal cancer is diagnosis. Hypocortisolism is not the diagnosis, it's a finding, like low HB. They have hundreds of cause. Low HB have hundreds of cause. Hypocortisolism, hundreds of cause. Hypercortisolism, hundreds of cause. That's it. So this is what the thing is, right? So you don't need to confuse in the exam now on words that what is the cause, right? So I'm very much pretty much clear from my side, right? So no need for this esophagoduodenoscopy and all blah blah. We already discussed it, right? So let's go and understand the last but not the slide for this. I have seen the doctors lots of confusion between hypercortisolism and hypocortisolism, or another word is Cushing's disease or syndrome and Addison's disease. Lots of confusion. And today your years and years of confusion will be clear in next 1 minute, right? Because it's a concept base. So simple, when there is a high cortisol, hypercortisolism or Cushing syndrome. Low cortisol
No.
is hypocortisolism or Addison's disease. Simple. This is the basic, right? Now going head to head comparison. How the Cushing's will present? Moon face, buffalo hump, central obesity, purple stria. Here the, or you can say here weight gain. Write down in your note is weight gain. This is the finest slide I brought it for you. Not routinely find in all MTB and other books. You need to research a lot. So weight loss here, weight gain here, weight loss. Hyperpigmentation, muscle wasting. Now hypercortisol. Here the word hyper. I will make your job very easy. Hyper and hypo. Hyper means everything is high. Weight is high. Blood pressure is high. Glucose is high. All electrolytes are high except high yield question in exam. Potassium. Only potassium is low in hypercortisolism. That's it. That's it. This is bottom line. So hypo means low. Hypoglycemia means low sugar. Hypotension means low BP. Right? So here hypo means weight is low. Hypo means blood pressure is low. Hypo means glucose level is low. Hypo means all electrolytes are low except here high potassium. That's it. Hyperkalemia, hypokalemia. That's all. That's all. If you remember this, 99% of job your is done. This is what they give you in the exam, right? So our patient has a adrenal insufficiency. So you see our patient has hypotension, blood pressure, patient presented with dizziness, right? Our patient is has a weight loss of 10 kg or 10 pounds. It is also there. Patient has all hyperpigmentation. It's all there, right? So this is a classical presentation of Addison's disease. That is what our thing is, right? So how you confirm is by cosyntrophin or synthetic ACTH administration. If your adrenal is working well, your cortisol will rise. If you have adrenal insufficiency or Addison's disease, in spite of giving external steroid, your will not improve because adrenal is absolutely shut down. So that's all from my side for Addison's and Cushing's. Is that clear to everyone? Yes or no? Yes or no?
Yes, sir.
Yes. Yes.
Wonderful.
Yes, sir.
Wonderful. Brilliant. Wonderful. I'm
Perfect.
trying my level best. Yes, please. Great. Let's move to the next question. Your homework is to go and read it once again. Adrenal, all Cushing syndrome and Addison's disease brings more clarity, right? I try to give you the concept. Rest of the things are there. First step in the management of acute severe hypercalcemia should be first step. First step. They are asking the first step. The first step in the management of acute severe hypercalcemia should be options are correction of the deficit of extracellular fluid volume, hemodialysis, administration of furosemide, administration of mithramycin, You want to give steroid to reduce the fast calcium bisphosphonate. I want to know what is hypercalcemia. So don't get confused. A lot of doctors are confused. Hypercalcemia means calcium is increased, right? Ca means calcemia, calcemia. And increased potassium is hyperkalemia. Kalemia. Kalemia means K. Kalemia K means potassium. Calcemia means calcium. So don't get confused between calcemia and kalemia. We are talking about calcemia. So calcium level is increased, which is acute and severe. So you need to know what is the normal calcium level. I'll get back to you. No worries. But meanwhile, if you have a patient of acute severe hypercalcemia, what the first step you supposed to do in this? And then I need one volunteer who can tell me ECG changes in hypercalcemia, hypocalcemia, blah blah blah. A lot of thousands of questions with this. Yes.
The ECG changes in hypercalcemia as short QT interval and widened T wave.
Okay. So
And
Dr.
hyp
Sonia, sorry to interrupt you. Can you tell
yes.
me what happens to P? Just I'm giving you the uh, question. Number one question is in hypercalcemia for ECG, what happens to P wave? What happens to QR waves, QRS interval? What happens to QT interval? What happens to, yeah, 1 minute. These all are questions. So we'll solve one by one. So P, QRS, QT interval, T interval. Is there any abnormal ECG can be seen which is pathognomonic for this hypercalcemia? Now you can start, please.
Sir, there is no change, change in
Yeah,
P
yeah,
wave.
Sonia. Why I wrote
There's
it
a
like this? Because it will bring the more clarity. ECG start with P wave. So what happens with P wave? It start
so
with the
P
QRL,
wave
QRS
so
and
P wave
Yes,
is generally normal in hypercalcemia.
normal, wonderful, brilliant, super brilliant, normal. We'll discuss
Yes.
later on. Okay, you get me your finding. What you supposed to think? What happens to ECG in hypercalcemia? P wave is normal. What happens to QR wave? Normal, widened, shortened. What is the pattern?
Sir, I think it's shortened.
Okay, I'll write down your. Okay, I will write down your
Shortened
findings.
QT.
Shortened. Okay, QT interval is normal, long, prolonged, or shortened.
Shortened.
Shortened, sir, this
Shortened.
one. QT
Okay,
interval short.
shortened. Okay, let's see shortened. Fine. What happens to T wave?
Flattening, sir. Flattening.
Flattening. Okay, flattening of. Yes, Dr. Sonia, would you like to comment on this flattening? She is saying flattening.
Sir, in hyperglycemia, actually, everything is shortened. Like QT is shortened, T wave is also shortened, except P wave is normal.
Okay, is there any abnormal wave? I mean, you can come across while you are studying your things, right? Hypercalcemia and EKG. Is there any abnormal wave? Can you know any name of the abnormal wave?
Osborne wave.
J wave.
Osborne wave, wonderful, brilliant. This word we hundreds of time we seen Osborne wave. Can anyone tell me what happens wrong in this PQRS in Osborne wave? What happens wrong, right? How you get to know, oh sir, this is Osborne wave? What is that?
The dome shape will be there, sir.
Where is in P complex, QRS complex, QT complex, T complex, U
In
complex? Where is the problem?
QRS complex, there will be a dome shape.
Doom shape. Okay, fine, fair enough. So you are close to the answer. So let's see. This is general, right? So this is normal. This is normal, right? So this is just for you to have idea. This is P. This is Q. Oh, sorry. This is Q. This is R. This is S, and this is T. Am I right? Right? Here you can see, right? Here you can see
Yes, sir.
hypercalcemia, right? Here you can see the T wave, right? And do you find any abnormalities in all intervals here? And do you find in hypocalcemia abnormalities here? This is classical picture. So let's dissect it. Bring more clarity. So in hypercalcemia, this is high yield slide for you. I'm just taking all high yield slide for the exam. Nothing is in the book. No comparison in any book. You need to find out the journal. right? So this is a high yield exam point of view table for hypercalcemia. So hypercalcemia QT interval is short. Here the QT interval is long. QT, right? We are talking about starting of Q to T, right? ST segment short, XT segment prolonged. Neuromuscular weakness because of hypercalcemia. Here no weakness. Here the tetany, hypocalcemia, tetany, cramps are there, right? Mental hypercalcemia can cause confusion. It does not cause confusion, anxiety and irritability. Classical signs, stones, bones, and gones, where this is seen, right, in the hypercalcemia. Chwostok sign, Chwostok. When you stroke on the angle of the jaw, there is a twitching of the muscle because of hypocalcemia. That is called as Chwostok sign. Most common cause of hypercalcemia, two cause. If they asking you in the exam, benign cause, right? Benign cause. Can anyone tell me what is the what is the cause of the hypercalcemia? Hypercalcemia, right? Hyperparathyroidism or hyperparathyroid adenoma or parathyroid adenoma. Parathyroid adenoma is the most common cause of hypercalcemia and most common cause of malignancy, right? Hypercalcemia. So number one cause is the parathyroid adenoma. So parathyroid gland is situated just beside or behind the thyroid gland. There are two pairs, two on the right, two on the left. Total number four, but pair is two, right? So this parathyroid gland per se has some kind of tumor in the parathyroid gland, and it secretes the hormone called as a prothormone, PTH, prothormone. And this PTH prothormone, right, it increases the calcium, right? Prothormone increases the calcium, right? So this is caused the commonest cause of the parathyroid, uh, right, hypercalcemia, right? So what are the causes of hypercalcemia as we have seen this, right? So this is done, this is done, this is done, this is done, right? This is done. Hyperparathyroidism and malignancy, here the most common CKD, kidneys, because of chronic kidney disease. Now it is not reabsorbed. Calcium, it is going out of the body. Hypocalcemia, vitamin D deficiency. In absence of vitamin D deficiency, calcium cannot get absorbed well from the intestine, and this is a hypocalcemia. So whenever this is very common in day-to-day practice, when you are in ICU, you are in ward, you have lots of hypocalcemia, right? Calcium level is less than normal. So think of vitamin D and chronic kidney disease. These are the two common causes. We are most common. We are discussing. There are a lot of causes. These are the most common. Here, hypercalcemia, IV fluid and bisphosphonate you can give. Here, no IV fluid, no bisphosphonate. Here, calcium gluconate. Because calcium is low, so you need to increase the calcium. How you supposed to increase? Give the calcium. The name of the calcium is calcium gluconate or calcium chloride. That's it. These are the things, right? So this is what the thing is. And last but not the least, somebody was asking me for the Osborne. So I did some more exercise on Osborne wave, and I got to find this picture, right, for Osborne. So this is all six blocks are for Osborne. Osborne wave identification. Notch at QRS complex end. So when QRS complex is end, there is a notch. This is Osborne wave. So this slide is done. What is Osborne wave? So Osborne wave is the wave at the end of the QRS. There is a notched wave. Notched at QRS is Osborne. Simple and sober, right? Which leads commonly seen in Osborne wave. So lead 5, right, or lead V2 to V5, V2, V3, V4, V5, V6. So chest lead, basically the chest lead, right? Second, done patient's management, address the underlying cause, whatever the underlying cause. Now you need to know what are the causes of Osborne wave, right? So hypothermia, one of the most commonly seen in the Western world, like Canada, US, where there is a too much of snow. Hypothermia, when your body temperature is goes beyond normal, very much low, it is called hypothermia. Another is hypercalcemia. We are discussing hypercalcemia. So hypercalcemia is one of the cause of Osborne wave. What is Osborne wave? At the end of QRS, there is a notch wave. This is Osborne. Exactly looks like this. If they had given you the picture in exam, you should remember this notch wave, right? Right. So that's it. This is what the Osborne wave. Everyone is clear for Osborne wave. What is Osborne wave? Yes or no?
Yes, sir.
Yes, sir.
Sir, in Osborne wave and M pattern, that left bundle branch block, how does it differentiate, sir?
Sorry, I'm not getting your question.
Sir, in Osborne wave, actually it looks like a M pattern in QRS complex in V5. In a left bundle branch block, also that M pattern, sorry, right bundle branch block, there is a M pattern in V1, V2. So, how does it differentiate?
Basically, this is at the end of QRS. Whenever you are thinking any MI, what I know is ST elevation. Here, no ST elevation. There is no ST elevation, right? This is P, this is Q, this is R, this is S. There is no ST elevation, right? So in acute MI, clear cut, there is ST elevation. This is at the end of the PQRS. There is a abnormal up-curve wave, that is Osborne wave. So whenever you want to see the Osborne wave, end of the QRSC immediate wave, right? Like this. So fix the picture. It is not a ST elevation, right? ST elevation we usually see in acute myocardial infarction, right? So don't get confused between elevation. This is not ST elevation, right? Because
No, sir.
there is
I'm not talking about acute MI, sir. I'm talking about William, left bundle branch block. In left bundle branch block in QRS complex, there is a M pattern. So it is very pretty similar to this Osborne wave. So I'm asking, how does it differentiate between this from the clinical scenario, or is there anything else to
Mainly the
differentiate?
clinical scenario, because when patient has a left bundle branch block or right bundle branch block, they must have hypertension, they must have chest pain, they must have some enzyme, they must have some history, they must have vital instability, right? So in every MCQ, each and every word is important. Age is important, extremely important. Sex is important, extremely important. Patient sign symptoms important. Patient's basic blood lab important. Until and unless you understand the stem of the question, it is very difficult to answer, because in exam it is very close answer, very close answer. I, I mean, most of the doctors, we all are brilliant, but where we do mistake is in the close answer, right? We confuse A or B, and we end up with the ticking the wrong answer. So try to make a habit of reading the MCQ. This is by my sense, right? Forget about options. Options has no value, right? Even if you know the MCQ well, you don't need to see the answer. You don't need to see the answer. Once you read it well, answer is there in the bottom, right? So whatever you are thinking, you can see that answer in the bottom, right? So that's it. So this is what the thing is. So not only the lab, or not only the lab is important, not only the history is important, you need to compile the complete whole picture. I will bring, probably you message me, I will share the head to head comparison between your answers, right? I'll do some exercise more, right? So to give you the head to head between lab bundle and Osborne, right? So again, go back to our questions. The first step in the management of acute severe hypercalcemia. So we have seen, Dr. Sonia, are you agreed with this, right? So hypercalcemia is a shortened ST elevation. It's a QT interval is shortened. So all shortened ST elevation, right? Or reduced short QT interval, Osborne wave, and it is fast repolarization because of calcium. There is a fast repolarization, and because of fast ST segment is shortened. QT interval is also short, right? So that is what the
Yes, sir.
thing is, and it's a reverse here, right? So now again, get back to the question: what is the treatment of choice? What is the treatment? First line treatment for hypercalcemia.
IV fluids.
Wonderful, brilliant. So it's a IV fluid. So this is what the short slide. I will dissect it a bit more. So hypercalcemia, when the calcium level is high, first thing is the aggressive IV fluid. Aggressive. The word is aggressive IV fluid, especially the normal saline. After that, the second most important step, you want to reduce the calcium fast. What increase reduce the calcium fast is a calcitonin, right? Calcitonin, can anyone tell me where is the calcitonin, from which gland it is released? Calcitonin, which gland release the calcitonin in the body? Like insulin is released from the
Parathyroid
tail of the
hormone.
pancreas.
Parathyroid.
Wonderful, brilliant. So parathyroid, has a two hormone, right? So one hormone is called prothormone, PTH, prothormone. I don't know why my slide is, my pen is gone little bit. So one is a prothormone. Prothormone increases, right? Prothormone increases, and one second. Yes. So there is some issues. Yeah. So growth hormone, it increases the parathyroid. Growth hormone increases the calcium, and calcitonin reduces the calcium. Same, right? Like insulin release both the thing, insulin and glucagon. Insulin reduce the glucose, glucagon increase the glucose. That's it. Likewise, right? So there is a two hormone which balance the calcium level in our body, right? So another is a IV calcitonin. Third thing is IV bisphosphonate long-term control. If you want to do long-term control, especially in a cancer patient. So we have many patients, breast cancer with bone metastasis and hypercalcemia. We give once a month bisphosphonate, long-term control. Loop diuretic after hydration, and if blood pressure is okay, you give the loop diuretic. Why loop diuretic? It removes the calcium from the urine, and it also reduces the potassiums as well. So you need to look into the parameters. Dialysis if severe, and renal failure. So any, right, so one of the cause of the hyper, right, so if patient has a renal failure, right, then dialysis, right? So these are the step you need to remember. You cannot avoid the IV fluid, you cannot avoid the calcitonin, bisphosphonate, diuretic, dialysis. So probably by my clinical experience, dialysis could be the last, right? Because we have many good drugs available in the market like calcitonin, hydration, right? And trying to underlying disease, if we keep under control most of the patients, right? So we have highest hypercalcemia patient in our OPD because of malignancy, right? So any cancer spreads to the bone, they may present with hypercalcemia, like CA breast to the bone, multiple myeloma to the bone, CA lung to the bone, then adrenal tumors to the bone, right? Or RCC, renal cell carcinoma. These are the common things which can goes to the bones very easily, right? So we have a lot of hypercalcemia, but rarely we need this dialysis for our patient. We hydrate them well. We give the bisphosphonate. We give the calcitonin. If does not get improved, especially with the renal failure, if the kidney is fine, 99% you don't need a dialysis. But dialysis, if severe or renal failure, then you can't do it, right? Whatever you give, right, kidney cannot remove it, right? So you need to remove through the dialysis. That's it. So this is what the thing is. So answer for our questions, right? What was the questions? Correction of the IV fluid and all, right? So this is what the first step here is, IV fluid and all, right? So if we go by the step, this is number one, right? Right. Second thing, after IV fluid, right, you can go for the calcitonin. Second is a calcitonin. Second is calcitonin, right? Third is a bisphosphonate for the long-term control. And if does not get control, then you go for the hemodialysis. So this is how the stepwise approach to the hypercalcemia, right? So you need to keep in mind how you supposed to treat the hypercalcemia, right? So this is all the explanation. I already told you. First step is aggressive IV fluid, and then why not hemolysis dialysis? Reserve for life-threatening hypercalcemia, not responding to fluid, not a first-line treatment. Furosemide, right? If you have good hydrated patients, right, then you give it. Otherwise, a dehydrated patient, if you give diuretic, they may worsen. So it's not a good idea. This drug is very rarely used. Steroids are used for hypercalcemia due to vitamin D excess, right? Sarcoidosis or lymphoma. So sarcoidosis and lymphoma with hypercalcemia, steroid can be used. Otherwise not. And bisphosphonate, very important, but they take 48 hours to work, right? And good hydration is required. The commonest complication of bisphosphonate again is on kidney. So before starting the bisphosphonate or zoledronic acid, we give in our day-to-day practice, we do the renal function test. Try to avoid if the EGFR is less than 30. That is a clinical tips from my side. So that's it. This is what the hypercalcemia. So I think I'm pretty much clear about all this logistic with the hypercalcemia, this hyper and hypocalcemia, these waves, the Osborne waves, right? What is the treatment plan? What is the, I mean, algorithmic treatment plan 1, 2, 3, 4, 5, right? Is that clear to everyone? Yes or no?
Yes, sir.
Wonderful.
Yes, sir.
Let's discuss another case. A 46-year-old woman comes to the office because of, I think we covered it. Sorry, we already did it. This cancer and all. This is little tricky questions, but important. And probably last, an 18-year-old woman, 18-year-old man present to clinic worried about his scant pubic hair development Examination revealed undescended testes and plasma testosterone. Luteinizing hormone and follicular hormones were found to be low. A karyotype test was done, which was 46XY. The patient was otherwise well, but during the neurological examination, struggled during the olfactory test. The most likely diagnosis is hypogonadotrophic hypogonadism, Klinefelter syndrome, androgen insensitivity syndrome, 5 alpha reductase deficiency, Kalman syndrome. Post your diagnosis. Yes. What's the diagnosis and why? I want to know the diagnosis. Dr. Khadija, would you like to comment on this? What's the diagnosis?
Yes, sir. I think the diagnosis is Kallmann syndrome.
Okay, so what point favors the Kalman syndrome? What is exactly the
Uh,
Kalman syndrome? Where is the problem in Kalman syndrome?
the problem is in the pituitary. It does not produce the FSH and LH required.
Sorry,
So,
can you repeat it? Sorry, I missed your point.
yeah, the problem is in the pituitary, the development of the uh, pituitary.
Problem is the
So,
pituitary.
yeah,
Okay, problem in the pituitary. Okay.
the FSH and LH is not released by the pituitary.
Mhm. What is the karyotype
So,
in Kalman syndrome?
when it's 46XY, it's normal.
Mhm. Okay, what is in the Klinefelter's disease?
There is 46. Uh, in Klinefelter's disease, there is only um,
In
I'm sorry,
Klinefelter,
sir.
47 XXY.
7 6Y.
What
XXY.
is in the okay? What is in the androgen insensitivity syndrome?
46XX. Sorry, XY.
Okay. What is in the 5 alpha reductase deficiency? Fine. So this
Not
looks
sure
to
about
be
that.
very tricky and critical for all of us, right? No problem. But just get ready in the exam. They will not ask you all the lollipop question, right? So let's dissect these questions, right? The answer is Kalman syndrome. Case summary. What is case summary? This is what this is given in the 5 6 lines is a case summary. So this is case summary. 18 years old man with 46XY, undescended testis. It is there. We'll see undescended. So for 18 years, right? We'll see all point. 18 years. Year 18 years. Second point, right, is a undescended testis, low testosterone. It is undescended testis is there and low testosterone is also there, right? So it is also there. Low FSH-LH also there. Scanty pubic hair is also there and is struggling for the olfactory test means anosmia or hyposmia. Smell is not good. So even with this only, it is diagnosis is Kalman syndrome. That's it. That's it. If you know the clinical picture, it is done. Whatever the Kalman syndrome has it, everything is there in the scenario. Why not the other option? Why not the other options? Right? So hypogonadism, hypogonadotropic hypogonadism, right? Why it is there? Not there. Low GnRH and low FSH-LH, right? This means the hypothalamus is not producing GN, means gonadotropin releasing hormone. Points to Coleman's or other causes, right? Key clue: impaired sense of smell, anosmia or hyposmia. This is a signature features of Kalman. So simple and sober. Whenever you are taking the answer in your exam for Kalman syndrome, look at the only one feature, and that is the smell, right? Smell, right? If the patient's smell is impaired, it is Kalman syndrome. Forget about everything. X, Y, XS, this, that, whatever. This is not present in any condition except this Kalman syndrome. So this is a signature features of Kalman syndrome, right? XY normal male chromosome. Kalman syndrome has normal chromosome. Klinefelter is what? XXY. XXY. We see more features. We see more features, right? Why not other options? Hypogonadotropic, right? It is a too broad, like it's like Cushing syndrome. In Cushing syndrome, there are a lot of things: pituitary cause, adrenal cause, other cause. Like the hypogonadotropic gonado, it's a broad term, too broad. This is a category, not a diagnosis, not the specific condition. Kalman syndrome is a specific cause of hypogonadotropic hypogonadism. Klinefelter's XY, so this is gone only by karyotype. Klinefelter's is gone. Why? Because it is not 46XY, this is 47XXY. Would show high FSH and high LH, not low. It's a hypergonadotropic, not hypogonadotropic. It is a small and firm testis, not the undescended testis. It is a tall stretcher, not associated with anosmia, which is a signature features of Kalman. And karyotype is 46XXY, not 46. So a lot of points not favoring the Klinefelters. Let's see other. What is androgen insensitivity syndrome? Testosterone and LH usually high. So in first step, it is gone. What our scenario is saying? Testosterone low, FSH, LH low, hypogonadotropic, hypogonadism. So this is high. So it is gone, right? Testes are undescended, yes, but this is the high level. And right, but what is another difference is here also karyotyping is 46XY, but normal olfaction, smell is normal in androgen insensitivity, while in Kalman that is a hyposmia or anosmia, right? And 5 alpha reductase normal testosterone, our testosterone in scenario is low, right? Then DHT low, external genitalia ambiguous at birth. You cannot differentiate between male and female. It's ambiguous. That is called ambiguous genitalia. Puberty causes virilization. Smell is normal. Smell is normal. No anosmia, no hyposmia, right? And not consistent with this case. So that's it. So smell, I think only if you go back to the scenario, everything is fit to the Kalman syndrome. A 18 years old man, yes, it's a male, right? Pubic hair is scanty, yes, pubic hair is scanty. Undescended testes, yes, undescended testes. Testosterone, LH, and FSH is low, yes, because hypogonadotropic hypogonadism. So all everything is low. Karyotype is normal, 46XY. Why XY? Because he is a man. If it is female, XX. So it is man, 18-year-old man, 46XY. The patient has otherwise well. Neurological examination struggled during the olfactory test means anosmia. So it is a Kalman syndrome. Is that clear? Is that clear?
Yes.
Yes.
Yes, sir.
Wonderful. Would you have energy to take one more question? I have full energy.
Yes, sir, sure.
Yes.
Wonderful.
Yes, sir.
One question will take.
Yes.
Patient came to you, and you found the blood pressure is 160 over 100. He is not on any medication yet. Laboratory investigation show creatinine 1.2 into bracket normal, sodium 145 close to normal, potassium 3.2 low, HCO3 is 30, 20 to 30 milliequivalent is normal. What is the diagnosis? Is it essential hypertension? Is it pheochromocytoma? Is it Addison's disease? Or it's a primary hyperaldosteronism? What is the diagnosis? How you supposed to investigate this patient? What could be the main treatment plan for this patient? Lot of question. Yes, please.
The diagnosis is primary hyperaldosteronism.
Wonderful, brilliant. So why it is not Addison's disease? Why it is not Addison's
It's
disease?
not Addison's disease, because in Addison's disease there will be hypotension, and this patient has an hypertension. The BP is elevated, which is
Wonderful,
significant with
brilliant. Wonderful. So
hyperaldosteronism.
wonderful. So
And the
And also,
potassium
sir,
is
there will be
potassium is low
hypotassium
as
in
well.
Addison
yeah, so
disease.
Addison's disease we see all low, hypocortisonism, and BP should be low. Here BP is high, right? Everything is low except potassium. So potassium should be high here. In our scenario, it is low. Is that clear? Yes or no? Right? So
Yes,
it is
sir.
not a Addison's disease. Simple
Yes,
and
sir.
sober. Essential hypertension is not there. Why essential hypertension is not there? Because in essential hypertension there is a no hypokalemia, no other things, otherwise fine, right? So it's just the hypertension, right? No other things. So this is gone. What scene you see in the pheochromocytoma? Basically, what is a pheochromocytoma? First of all, tell me what is pheochromocytoma?
And there's a tumor in the renal medulla.
Okay, wonderful. So it's a tumor of suprarenal gland, isn't it? Yes or no?
Yes, sir.
Wonderful. So it's a pheochromocytoma. So do you see hypokalemia in pheochromocytoma?
No, sir.
Wonderful. So that is also gone. So our diagnosis is primary hyperaldosteronism. Now, can anyone tell me what is the treatment of primary hyperaldosteronism? If this patient, I want to control the blood pressure of this patient, what is the drug of choice? Because patient has
Aldosterone
160 over 100
antagonist.
BP. I
Potassium
want
sparing diuretic, sir.
potassium sparing diuretic. Can you tell the name of one potassium sparing diuretic?
Spironolactone.
Spironolactone. What is
Spironolactone.
the concern side effect of spironolactone?
Gynecomastia, sir.
Increases the
Wonderful.
potassium.
Wonderful. So both are correct. So spironolactone, it increases the potassium because potassium is sparing, and another important is gynecomastia. So is there any drug which can have no side effect of gynecomastia and also used in this? Patient is concerned about this gynecomastia. Patient is quite
Who's
educated.
semi?
When you explain, huh?
Semi. Who's semi?
Furosemide is not a potassium
No,
sparing.
it was
It is not a sparing.
hypocalcemia.
Eplerenone.
It is
Epinol.
not, but potassium sparing is not. It is not this potassium sparing. So your homework to
Aldactone, sir.
find out. Sorry,
Epinol.
which drug?
Lisinopril.
Epinol.
Good, wonderful. Those who don't know, go and read it. Drug of choice for primary hyperaldosteronism to control the blood pressure, which has no side effect of gynecomastia. This is specific questions to you guys, right? So, what is the answer? Case summary is what? BP is 160 over 100. Yes, not on any medication. Yes, sodium 145 is high normal, but it's normal. Potassium is low 3.5. HCO3 is 30, but higher normal, high, right? And creatinine is normal. These three findings together high in hypertension, hypokalemia, metabolic alkalosis, primary hyperaldosteronism. The name of this condition is called Cone syndrome. Cone syndrome, right? So you just whenever you answer the hyperaldosteronism, primary hyperaldosteronism, look at the three things: hypertension, hypokalemia, acidosis. Sorry, alkalosis, because this is high, right? So that's it. What's the other things are important in this? Why not essential hypertension? BP elevated, but electrolyte should be normal. It's gone. Pheochromocytoma causes paroxysmal hypertension. What do you mean by paroxysmal hypertension? Means periodic hypertension, right? Headache, sweating, palpitation, nothing is there. Apart from that, potassium should be normal. Electrolyte is normal. We have hypokalemia. Addison's disease, low sodium, high potassium. It is gone. Our scenario is low potassium, right? Metabolic acidosis. So that's it. Favoring all the things, it fits to the primary hyperaldosteronism. The name is a Cohen's disease. So that's all from my side for today for endocrinology. Thank you very much all for joining me today. Before I end up my session, if you would share your opinion or your feedback, how was the class? How did you enjoyed? I enjoyed 100%, but how did you enjoyed? What was the learning? What you learned new things today? That is very important. Anyone? Yes, please.
So actually, before attending to this class, I go through the endocrinology all questions. When I'm doing these questions, I have a lot of doubts. Sometimes I feel that the Q bank is wrong. But after attending to the class, this class, all my doubts were cleared, and I feel the way to see the questions is different. So all the way to see the questions is taught by you. But after attending the class, I think I can see a different way in the questions, and it will help me to find the most suitable answer.
Wonderful. Thank you very much. So do practice.
Thank you very much.
It's a long exhaustive subject. So, but I'm trying my level best. Yes, Dr. Savita.
Yes, sir.
How?
It was really nice, sir. Long back, I had read Spiroff. I felt similar way, sir.
So what did you learn something new today from your routine preparation? Because everybody is preparing in their own way. So what's the difference?
Yes,
I mean,
I've just started, sir.
wonderful.
Again, same way. I'll have to go back to the subject wise, and then when I start going through the subject wise, then probably I'll have many queries, and then I will understand, sir.
Wonderful. We'll learn it. Wonderful. Yes,
Yes.
Kings. Anyone else? Yes. Yes, Sonia. How was your experience?
Yes, sir. Thank you, sir, for taking this session. I think it has cleared a lot of doubts, and in a concise way, you have explained so many things, sir. Thank you so much for that, sir.
Wonderful. Brilliant. Thank you very much for your kind feedback. Yes, Rabia Bibi. How did you learn and enjoy it?
Sir, I enjoyed a lot. You clear all of excepts of endocrinology. Really appreciate.
Thank you very much for your kind feedback. Yes, Ranmini, Purnima, Najir. So I think you have to be a little bit more interactive in general, not to anyone special, because when you discuss the question, right, forget about right or wrong. This is, I think, the best platform. We can openly discuss anything, right? So don't shy, don't hesitate, because once you discuss, I think so, you never ever forget, never ever forget, because when you discuss something, yes, Zuleka.
Sir, wonderful class of endocrinology. You clear each and every aspect of the Cushing syndrome, Edison disease, difference between all these. So wonderful, wonderful. Never before I seen these slides. Thanks a lot.
Wonderful. Thank you very much. Yes, Khadija, last but not the least, how did you learn today? How was the learning?
It was a great class, sir, as always. Again, I found that you've made the concepts very simple and easy to understand and follow.
Wonderful. Thank you very much, everyone. We'll see you with the next class, probably next 3-4 days. Keep a watch on your message. My message is always important. I will not message good morning, good night to anyone. When my message comes, something with the coaching. That's it. So just keep in touch and we'll see you. Thank you very much and enjoy your Sunday. Thank you. Bye. Take care.
Thank you, sir.
Very much, sir.
Thank you, sir.
Thank you very much.
Thank you, sir.
Thank you. Take care.